All right. I want to focus on arrhythmias for a little bit. And this is the tail end of that list that we were going through on the previous video, which was potential consequences of myocardial infarctions. So arrhythmias are, or dysrhythmias, either term could be used, can definitely be a consequence of myocardial infarction. And as you can see on the slide there, about 90% of people who have MIs end up with some sort of dysrhythmia. And that can be due to a couple reasons. One is that the chemical changes that we see at the tissue level as a result of ischemia can precipitate arrhythmia. And also the reflex autonomic responses can precipitate an arrhythmia, as well as electrolyte imbalances, which we'll see when there's low cardiac output and blood flow to the kidneys that can precipitate electrolyte imbalances, which we'll learn about later on in the semester. Lots of medications, cardiovascular medications, cause arrhythmias as a side effect. So that's another reason why we might see this. And so these medications can be used before and also after myocardial infarctions. But one of the challenges with cardiovascular medications is that many of them, if not most of them, cause can have as side effects other cardiovascular issues, and dysrhythmias are on the list in many of them. All right, so there's a whole bunch of different types of dysrhythmias. We're not going to talk about all of them, but I'm going to kind of run you through what you can see. So there are really three major kinds. One would be as a result of abnormal rate. Another one would be an abnormal site of impulse formation, and the third could be abnormal impulse conduction. And so those translate into these different arrhythmias or dysrhythmias. And there's different, like I said, there's lots of different ways to kind of classify this. This would be the most general, which would be, those that affect impulse formation, those that affect conduction, and those that affect rate. And then we can go a little bit more detail from there. So it's just some terminology that you may or may not be familiar with. I'm sure you are familiar with, but one is tachycardia, or sometimes you'll see tachydysrhythmia, which are disorders that exhibit a heart rate of greater than 100 beats per minute. So tachycardia is generally classified as greater than 100 beats per minute. The increase of tachycardia increases in older people and in people that have already pre-existing cardiovascular disease. So when we talk about dysrhythmias or arrhythmias, we can see the abnormality in either the atria or the ventricle. So if this was in the atria, we would call this atrial tachycardia. If it was in the ventricle, you would call it ventricular tachycardia. In both cases, we're looking at a very rapid impulse, very rapid firing, if you will. In the atria, it's very rapid firing of the SA node, or sometimes another focus, an external focus in the atria that surpasses the SA node and basically surpasses the SA node as the pacemaker. Okay, bradycardia would be the flip side of this. This is an abnormally slow rate, which would be under 60 beats per minute. Bradycardia is a little bit harder because for some people, under 60 beats per minute is normal. So really the more significant thing here is if it's a change for somebody. If their heart rate is normally higher and then all of a sudden it's low, that's more significant. Flutter is a very rapid but regular heartbeat. And we can see the atria beating at like 250 to 350 times per minute. So during atrial flutter, remember the job of the AV node is to selectively block some of these impulses. The AV node is limited to 200 beats per minute. So the job of the AV node is to kind of block this crazy transmission into the ventricles. So oftentimes what will happen is the ventricular rate will be slower than the atrial rate. One more. And then there's atrial fibrillation. So fibrillation, or I should say fibrillation in general. So we have atrial flutter only. There is no such a thing as ventricular flutter. But fibrillation can exist either in the atria or the ventricles. And basically, fibrillation is a complete disorganization of rhythm. And the consequence of this is you get no coordinated contractions. So completely uncoordinated. It's basically the heart is quivering. And like I said, this can exist in either the atria and the ventricles. It's very dangerous in both. It's most dangerous. It's the most dangerous dysrhythmia is ventricular fibrillation. Atrial fibrillation is actually quite common. It's the most common dysrhythmia, actually. And it's caused by multiple sites of impulse formation throughout the atria, all firing chaotically. So the rate is like somewhere in the range of 300 to 600 beats per minute. And it's causing the ventricular rate to be really, really disorganized as well. And it could be anywhere from 50 to 200 beats per minute. Kind of depends. But the key to this is this loss of organization, the loss with the atria. It's the loss of organized atrial contraction, which can actually cause some of the parts of the heart the atria not to be contracting, and that can give rise to clots. So a big risk of atrial fibrillation is strokes, and that is why people who have AFib are oftentimes treated prophylactically to minimize their chances of having a stroke. So they'd be put on some sort of anticoagulant as a result of that, or some drug along those lines. So, and then ventricular fibrillation, I mentioned, is a complete disorganization of the rhythm in which the ventricles pump nothing, no blood, little or no blood. And that results in the body tissues being quickly starved of oxygen. And I think now most people, if not all people, would consider ventricular fibrillation equivalent to a myocardial infarction or cardiac arrest. Okay. So here's some pictures. Normal sinus rhythm on the left, that's completely normal. Tachycardia is coming a lot faster. We're talking about 100 beats per minute. Bradycardia is super slow. This is actually an exaggerated bradycardia. It's the result of actually eliciting the parasympathetic nervous system by putting pressure on the carotid sinus, which actually causes that paradoxical, if you will, or that vasovagal sort of response where you see a exaggeration in a greatly exaggerated slow heart rate, bradycardia. Atrial flutter. Everywhere we see an orange triangle pointing up, that's looking at a P wave, and the yellow, or not orange, red, pardon me, and the yellow are looking at QRS complexes. So you see there's a lot more happening in the atria than is in the ventricle, and that's sort of indicative of atrial flutter. We mentioned sometimes that, so that was kind of just rate stuff. And then we have situations where you've got this ectopic beat, which can cause any of those abnormalities that we just talked about. Ectopic beats can cause atrial fibrillation. They can cause, or atrial flutter. They can cause ventricular fibrillation, ventricular tachycardia. So anytime you have an ectopic beat, it just means that the site of impulse formation is someplace other than the normal conduction system, so other than the SA node. So sometimes you can have a very slow SA node, and therefore these escape beats can be very, very helpful because they can actually get blood out of the heart. Sometimes these ectopic beats can actually get in the way, and they're oftentimes referred to as premature beats. And if it's in the atria, it would be a premature atrial contraction. If it's in the ventricle, it would be a premature ventricular contraction. Now, so to the third category, which is conduction issues, this is where heart block comes in. So heart block is what it sounds like. It's a block of the conduction from the atria to the ventricles. Basically, the AV bundle is not conducting the impulse. So there's different degrees, and you're not responsible for this, but I'll just put them up there. The first is called first degree, which is not a big deal. The conduction slows, and how you would know that is the distance between the P wave and the QRS complex gets slower and gets longer and longer. But your P wave, your QRS complexes are always followed by the P wave with first degree. It's just the conduction that's off. The rate is okay, but the conduction is off. Second degree, there's type 1 and type 2. In type 1, we see the conduction getting slower and slower and slower, and then you'll skip a beat. And then if it's type 2, you just skip a beat on its own. So that's what's happening there. The pink dot on the first is showing the skipped beat. And on the second picture there, you're seeing just the skip, not the slower and slower, slower in the skip, sorry. And then the third degree is like complete block. So the atria is doing its things, the ventricle is doing their things, they're not unified at all. Again, you're not responsible for knowing the first, second, or third degree. I just would like you to know what I would like you to know what a AV block is. One thing that that is helpful to sort of think about. So with an AV block, one of the things you may see if somebody develops an AV block is that what you would see is a sudden bradycardia, right? Their heart rate would go down because if they're not, especially if they've got a third degree heart block, because the conduction tissue in the ventricles depolarizes much more slowly than the atria. So if you electrically isolate the atria and the ventricles, what that would actually look like is they would be relying on their ventricles to get the blood ejected, right? And so their heart rate, their pulse, their heart rate is going to go down because of the fact that they're not able to, because the ventricles are depolarizing so much more slowly. So that would be something that would be a clue, right? If somebody normally has a heart rate of, 75 resting and all of a sudden it's down at 40, that's weird. And that says, oh, wow, something strange is happening here. And that's one of, not the only option, but that is an option. Okay, so we're going to talk about some interventions here that are indicated for use with cardiac ischemia and how they act. And this is going to be quick, right? Because this is not a class where we really talk about intervention or treatment. We really talk more about progression of the disease. But I want to introduce a couple things here. So we're going to look at drug and oxygen therapy for a second, mechanical assist devices, such as intraaortic balloons. We'll look at some talk for a second about surgical intervention, mostly bypass, angioplasty, aneurysectomy, aneurysmectomy, septal defect repair, and valve replacement. So, medical intervention with ischemia. So really what this all comes back to is oxygen supply must meet oxygen demand. So our approaches are going to be potentially drugs and or oxygen, mechanical devices, or surgery. So let's talk about drugs and or oxygen first. So one way we could decrease demand. So remember, our choices here are decrease demand or increase supply. So one way to decrease demand is to decrease the work of the heart. So you could decrease heart rate, you could decrease the force of contraction, you could decrease arterial pressure. So all of those things would decrease demand. So we have drugs that decrease heart rate and force of contraction, and drugs that lower arterial blood pressure. They have other consequences, many of them are cardiovascular, but they definitely do decrease, demand. There is some evidence that some drugs, most notably the ACE inhibitors, are potentially effective at decreasing ventricle size, but I think we would want to put a caveat on that in terms of as long as the ventricle is not way enlarged. Once the ventricle is like severely enlarged, I don't think there's any real good evidence that any drugs are going to be significantly able to decrease the ventricular size. However, there definitely are drugs to take some of the burden off of the heart and decrease blood pressure, and that will be helpful in these situations potentially. The obvious choice would be to increase oxygen supply, but that's not all that, because of what we've already talked about. The myocardium really takes all the oxygen out of the blood, even at rest, and if there's any disease in the vessels, if they have any coronary arterial disease, that's going to kind of be off the table because they're not even able to vasodilate. And even if under best case scenario, they can only really increase blood flow 4 or 5 times, and that's not, sometimes as the demand continues to escalate, that probably isn't going to be enough. But there is some role of oxygen here. One of the things you can do is you can increase blood pressure, which would, push blood back into the coronaries, but that's going to increase work. So that's sort of the double-edged sword there. If the blood supply, the pressure is too low to actually supply the myocardium with oxygen, then that might be your only option, but it's going to also it's also going to increase demand. So there's not a way to increase blood pressure without increasing demand. And then fibrolytic therapy is a potential to this has more to do with decreasing the likelihood of clots, which would also sort of increase supply, provided there is a clot. All right, let's talk about mechanical assist devices. So there's a couple, and I have some pictures. Sorry, there's a typo there. These are devices that are used to either partially or completely replace the function of a failing heart. So basically, this is kind of like a pump, and the blood gets sucked into the pump, and then the pump shoots it into the aorta or into the pulmonary artery. So it's essentially taking the place of the ventricle. So they have left ventricular assist devices or right ventricular assist devices. In most cases, it's the left side of the heart that's the problem. So left ventricular assist devices are going to be much more common. They are not a forever fix. I at one point went looking for to try to figure out who would survive the longest with a left ventricular assist device. And if I remember correctly, I found like 10 years. That we may be better. So really these kinds of things are put in place while someone's like awaiting transplant or something along those lines. The heart has already failed and we're taking the place of the ventricle. So this is not like your forever fix, but it's an effective kind of bridge to an additional surgical procedure, most likely. Then there's intraaortic balloons, and these are kind of interesting. I have a picture. It's sort of a similar concept, but there's a balloon that sort of gets threaded and it inflates. It has time inflation and inflates with the cardiac cycle. So it inflates in order to it inflates to increase diastolic pressure, which improves perfusion, and then it deflates to decrease end diastolic pressure. So that decreases some work. So it decreases myocardial oxygen demand and it increases cardiac output. And again, this seems to be especially helpful in cases of cardiogenic shock if you can get it in place fast enough, and also some significant valve or septal defects. I think I have a picture of both of these devices. So this is the LVAD. And so you can kind of see the blood from the left ventricle flows into the device, the pump, and then the pump gets inserted into the aorta. So you're basically taking the work of this is become your left ventricle. It's a pretty cool device. It's battery operated and all of that. This is an intra-aortic balloon pump. So it's inserted into the aorta, and you can sort of see how it's threaded up here, right? So it's threaded up through the aorta. And again, this is more detail than you need, but it just sort of helps you to understand. So the pump, the intra-aortic balloon pump, has this balloon and a pump that inflates and deflates the balloon. So the pump, it operates the balloon, if you will, and it does this in concert with the EKG screen as at somebody's bedside. And so the balloon is inserted, like we saw, say here, through the femoral artery, and it's threaded all the way up into the aorta, and then it inflates and it deflates at specific times, you know, of the cardiac cycle. It's timed during the heart's contraction, and it both supports circulation to the extremities and also back into the coronary arteries, which helps to force blood into, you know, force the blood to the heart muscle. So it increases perfusion to the heart and decreases the work, essentially. So they're pretty cool. Okay, and that is another option. And then we have bypasses and angioplasty, and then we can surgically repair aneurysms, if that's the case. That we can go in there, and so a bypass, I don't know that I have any pictures. So a bypass is kind of exactly what it sounds like. So you have an area of occlusion, and ideally you catch it before you have an infarct or even ischemic damage. And then you can go in and you just get a vessel from someplace else. Usually they'll take a vessel from someplace else, usually the leg, and they'll go in there and they'll sew it in, and they'll bypass that lesion. Oftentimes stents are placed for this kind of the same purpose, kind of holds open a vessel, you know. Stents seem to have kind of a window of time where they're effective, and then it seems like we plaque around the stent. I mean, unless somebody really changes their lifestyle, you know, that's again, it's sort of a Band-Aid, you know. You got to do something to get on top of why you have this coronary artery disease to begin with. Angioplasty is sort of similar to a stent in that they basically put a balloon, like kind of a balloon in there, and sort of blow it up, and that opens up the vessel, and it helps to restore blood flow. So an aneurysmectomy would be surgically repairing an aneurysm, which is a grossly dilated and weakened wall. The septal defect repair goes in and sews up that hole we talked about before. And then valve replacement is another option if the valves are problematic, and that's done frequently and very successfully at this point. Okay, I'm gonna stop here, and I'm only gonna do one more video. I'm trying to limit this to 3 hours because that's how long your class is, and you've got to be exhausted listening to this because I'm exhausted from recording it. I don't know how we do this for 3 hours every week. But I'm going to do one more video, and that should get us to the 3 hour mark. And then we'll be able to hopefully finish the cardiovascular system when we come back to class next week. So our final video will be on valve disorders, and we could spend hours and hours talking about valve disorders, and I'm not going to do that. I'm going to abbreviate this as much as possible. Just sort of the need to know to help you, to assist you to understand what's going on with valve issues. So one more video after this one, and you guys will know a lot more about the cardiovascular system, hopefully.